So the kind of people that come to our program are often people who are coming out of their depression. They may have been treated with an antidepressant. They may have been seeing a psychotherapist, and to a large measure, the treatment seems to be working. But as we know, in depression, there is still the need for prevention of relapse. Depression tends to return once people are feeling better if they're not doing something to look after themselves. And some of the ways in which they learn to look after themselves is to work more wisely with moments of fear, moments of sadness when they just show up, as they do to all of us, and not fall into a sort of depression trap where they start to think again as if they were depressed. Mindfulness and the program that we've developed offers them an opportunity to practice on a daily basis being with frightening thoughts, sad feelings, or other ways in which the mind can very quickly jump to conclusions. And by allowing them to just watch and observe these phenomena or these events, they're better able to choose how to respond to them. So for example, I can think of a patient of mine who was working as an accountant at a very stressful job, especially around tax time, and was depressed and was coming out of her depression at around the time that the tax season was getting started. And she was able to return to work and stay focused and productive because during the day she would take brief 3-minute breaks, sit, tune into her current experience, maybe use her breath to allow her to return to the present moment, and in this way regulate herself when she found that the pressures were mounting or her mind was telling her that she couldn't do things or she wasn't ready yet. And she looked after herself in a very effective way because she could draw on these new procedures. That would be one example of the way in which people are able to incorporate these practices. And the difference, I guess, is that she was no longer in therapy and she was no longer in the mindfulness-based cognitive therapy group. But because she was practicing on her own on an ongoing basis, perhaps using tapes and CDs to help her, she was able to bring this into her everyday life. Certainly, depression and relapse into depression has a significant cost because it requires re-entry into the medical system, it requires retreatment, and other associated costs on family members can also be quite high. So to the extent that people are able to look after themselves, there ought to be substantial savings. The number of Canadians, the number of North Americans that are on antidepressants is really quite high because antidepressants are still the first-line treatment for depression. In many cases, people might want to take an antidepressant and also participate in mindfulness-based cognitive therapy. Many of the studies show that when people take an antidepressant, they only take it for a very short time. The recommendation might be a year. They may only be on it for about 2 or 3 months before taking themselves off it once they feel better. Therapeutically, this is actually not a good idea because the depression might still sort of be raging underneath, and the antidepressant, once it's no longer being taken, might allow the depression to sort of break through. So in some ways, MBCT might be helpful in terms of keeping people on an antidepressant and letting the drug do its work. On the other hand, there may be, for some people who have been on an antidepressant, the possibility of coming off the drug and using the practices of mindfulness-based cognitive therapy to keep themselves well, to provide them with the prevention that a drug may have provided for them. And that would be the case for people who are already quite well and who have been well for, let's say, 4 to 6 months. They are not that different from what people might find if they went on a 7-day silent retreat. We teach patients very similar types of practices with sitting with the breath, mindful walking, mindful stretching or yoga, as ways of providing them with an opportunity to gather themselves in the present moment and to be grounded in the midst of a mind that might be racing and pulling them in many, many different directions. So the actual practices are not that different. It might be fair to say that the method of delivering them has been changed somewhat to emphasize the mental health or the health context. That's the primary reason for people coming to see us in the first place. Yes, I have a mindfulness practice. I've had one for the last 12 years, and part of that developed from the incredible adventure that I and my collaborators went on to develop this treatment. We started out as psychotherapists and ended up being mindfulness practitioners who who were involved in developing this form of psychotherapy. Part of the reasons for developing a personal mindfulness practice, I think, came from needing to have the credibility and the understanding of being able to teach this to other people from a place that understood emotions, that understood the mind and thoughts, from the perspective of what mindfulness allows you to see. And in order to do that, we needed to practice ourselves. So this is not just something that we've taken on board ourselves. We've actually now worked it into the teaching of MBCT as a recommendation for therapists. If they want to work using mindfulness practices with their patients, they need to have a mindfulness practice themselves. This is a fundamental, almost non-negotiable principle for us. I think the capacity that people have for treating others with compassion is one of the things that can very easily fall out of a mindfulness practice. And so, in a sense, in the world, those kinds of acts are very important. Mindfulness practices may be one way of allowing people to access that intention within them, but there may be, and there certainly are, other ways of doing that as well. And the more of those that can be accessed and disseminated, probably the better.